Doctors across the country are dealing with unprecedented levels of traumatic stress, not only from the sheer pressure from their jobs, but also the moral decisions they're forced to make in split seconds. The Atlantic took a closer look at how New York City doctors and nurses were pushed past their limits during the height of hospitalizations earlier this year. Due to the lack of ethical guidance from the city and state officials, many doctors faced moral dilemmas, like which patients should get ventilators and which patients are too sick to save. Those decisions continue to haunt many of our frontline workers. Joining us now is the author and the writer of that piece, Jordan Kisner. She's been reporting on this for quite some time. Jordan, thanks for joining us, because it's a really fascinating article that you've written, and you really dig into what's going on with some of these frontline heroes. But before we get into your piece, walk us through why the bioethics field was created for medicine and how it's supposed to help in situations like this. I mean, there are sort of guidances that have existed for many, many years, but perhaps this pandemic upended things in a way that were not sort of thought of.
Yeah, so ethics, as we know, has a long history. The field of ethics pre-exists the field of bioethics, where you see the need for ethics to be applied specifically to the behavior of doctors and scientists really emerged in the 20th century as the power of doctors and scientists to save lives and maybe then to cause harm really increased. So the need for bioethics was identified kind of around the mid-century when we saw a lot of horrors coming out of the scientific community. The experimentation of doctors on prisoners in the Holocaust, the Tuskegee syphilis experiments. So in the mid-century, there was this feeling of like, oh, somebody needs to be making sure that scientists and doctors in the medical community are doing right by their patients who are vulnerable to them in new ways. And so bioethics as a field has emerged to be related but independent advisors, ethical and moral advisors to the scientific community. So they help decide what is the most ethical way to administer a vaccine trial. What is the obligation of the doctor to a patient in a hospital? And in a way, the field was really well set up to attend to a pandemic like this. Bioethicists have been thinking about what happens when a public health crisis overwhelms our public health system for many years now. What the bioethicists told me, who I spoke to, was that we were maybe less adept within that field to think about community responses. There's been an effort to think about like the rights of the individual patient and less to think about how we ethically manage a crisis that impacts mass communities of people.
So, in the beginning of the pandemic, New York was hit very, very hard. It was when we were really just learning about the best ways to treat people who are suffering from the virus. And essentially, doctors were trying whatever they had in their toolbox and at times not being very successful. Why didn't New York Governor Andrew Cuomo or Mayor Bill de Blasio take action to declare these hospitals in crisis? And what effect did that have on hospitals left overrun with COVID?
So the Cuomo administration focused its effort on trying to ensure that rationing would never have to happen. Rationing was the big fear. What if we run out of ventilators? What if we run out of the supplies? What if we run out of doctors? What if we run out of beds? And the Cuomo administration took the approach of radically increasing the supply to the medical system so that rationing would never have to happen. And they did a really remarkable job doing that. What doctors and medical associations were saying from the front lines and have continued to say is that despite their efforts, rationing was happening already. There was not enough PPE. Sometimes there were enough ventilators in the state, but not all the ventilators were in the right hospitals. There was a shortage of staff. There was a shortage of beds. And so from a policy approach, not addressing the fact that rationing and prioritization and what we would call crisis standards were already being enacted in hospitals left each individual hospital and the doctors at those hospitals to try to figure out rationing on their own, rather than implementing what was a pre-existing plan created by bioethicists and public health experts and doctors for what should happen, what should the baseline protocol be for all New York hospitals if such a thing were to occur. And so there were a lot of bioethicists calling from New York at the time for implementation of what those are called crisis standards of care, that kind of policy. And that didn't happen. That has to flow through the governor's office, and that didn't happen. Though I would point out that crisis standards of care were not enacted in almost any state in the United States. That, for whatever reason, is a step that very few state governments have been willing to take.
Jordan, through the course of your reporting and your research, explain to our viewers how race factored into this.
Well, as we know, the coronavirus has decimated communities of color. It's disproportionately reached and caused death in, Black, brown, and Indigenous American communities. What the bioethicists I spoke to told me is that what the pandemic has done was highlight existing inequities in our healthcare system, which are an ethical and moral problem. So in New York, what you saw, for example, is that in Queens, which is where I live, the hospitals were absolutely overrun. There was a much greater need for rationing. The shortages were so much more acute in certain hospitals in Queens, in the Bronx. I spoke to healthcare workers and ethicists at the Montefiore hospital system in the Bronx. And what they experienced was so much more dramatic in terms of resource scarcity. And what you're seeing there is the way that the coronavirus, the pandemic has flung us into conversations about prioritization. Who gets the priority for a ventilator? Who gets the priority for a vaccine? But what the virus has done has shown us already which communities we are deprioritizing in terms of medical care and access to medical care before anyone ever got sick.
When you talk about prioritization, family members, they dropped way down on the priority list in a situation like this. Many of them were not able to see their loved ones, were not able to be close to their loved ones as they battled this and at times succumbed to this virus. Can you talk a little bit about the ethics surrounding that?
Yeah, this was something that all the bioethicists I spoke to who were in charge of helping to create policy for how to get all of the doctors, nurses, techs, cleaning people, and patients through this surge in the most ethical way possible. They really wrestled with this question of their duty to reserve PPE for, say, the doctors and nurses and techs who were immediately interfacing with very sick patients, their duty to try to save lives, to reduce the spread, which we know is so important. That was a reason to keep families out and to really try to isolate patients. But at the same time, they've said, in retrospect, the situation that caused, which was the isolation of patients dying alone or in front of iPads, unable to see their families, created so much horror, so much moral distress, and actually so much moral and ethical stress on the healthcare workers who had to step in and be family, which is not something that they usually do. They usually keep a little bit of emotional distance from their patients because they need to be able to have the resilience to lose patients and go on and give good care to the next patient and not burn out. And that was one of, as far as they've told me, one of the most painful ethical conundrums that they faced in terms of creating hospital policy.
Yeah, I was thinking about sort of all the interviews that we have seen, Vlad, of frontline workers sort of breaking down, really tearfully pleading to the public to follow the guidelines. And I thought to myself, they're not used to this much loss. People come to the hospital to be treated and often to get better and then leave. And often they don't stay for, we hear of people on ventilators for, a month or 2 months. And so these nurses and doctors have not had to deal with this kind of, I think, sort of in-your-face, the intimate nature of treating somebody who is sort of slowly spiraling downwards. And maybe in some areas, maybe some sorts of medicine, but I don't think this type of medicine, they were really used to it. And I don't think they were trained for it. And what you're bringing up here when you talk about the ethical dilemmas is something that hopefully there will be lessons learned that will change the way medicine is practiced in the future. Did some of the ethicists talk about that, about maybe the evolution of medicine because of the pandemic?
Oh, the evolution of medicine, I think, is constant. They talked a lot about the evolution of their own field of bioethics, and the way that they suspect that their field could do a better job at speaking about inequity, pre-existing inequities that helped to create the clinical crisis in the hospitals where they work. In terms of adjusting to what they've learned, what they learned in the surge in New York and what now hospital workers are learning all over the country, they said that they had hoped that what they went through in New York would be a signal to the rest of the country about how absolutely serious this was. And they hoped that it might have promoted more mask wearing, more willingness to sacrifice, given the unbelievable suffering that they witnessed and underwent. And there was real sadness and frustration that their experiences had not been more instructive to the rest of the country, as we now see what they went through in April in New York is happening everywhere.
Jordan, Anne-Marie, that's exactly what I was thinking of when I was listening to you, Jordan, which is that doctors have gone to war. Doctors have faced pandemics in the past, but we've never lived through a pandemic with so much information at our fingertips. And I cannot imagine what someone who's a doctor, who's a nurse, who's a medical professional, people who clean in the hospitals, people who serve food in the hospitals must think about when they realize that, especially now in December, that a lot of this is preventable. Maybe not back in February and in March, but now certainly in December, it was preventable. It is preventable, and yet the numbers are going up. And what that must do to your mind, because accidents happen, people, get sick, people are in car accidents and they get hurt, and that's normal. And I think a doctor is prepared and trained to deal with that. But when you're dealing with a situation where everybody has the information to stay safe, everybody has the information to not end up on a ventilator, and yet the numbers are going up, what that must do to you and how you process that.
Yeah, I think you're exactly right. And we're seeing unprecedented levels of burnout among medical professionals. In New York in the spring, there were a number of people who had been, doctors and nurses working in the hospitals in the surge who died by suicide. There are stories right now about unprecedented levels of early retirement among medical professionals, people exiting the field out of fatigue, out of frustration, out of heartbreak, out of burnout. A lot of the people that I spoke to who had direct experience working in hospitals suggested that the next great problem, epidemic, is going to be of PTSD among medical care professionals, and that is something we have yet to touch.
Yeah. Jordan Kisner, great conversation, great article. Thank you so much.